Okay, good afternoon again. Uh, how do you do it now? But let me try and remember how official people do it. You have to welcome honorable guests. We like to acknowledge the presence of Professor Duncan, our teacher. Um, so, since my old prof is here, I have to no more jokes. Very serious talk this time. All right. So what we're going to talk about now is heart failure. I think we've done a lot of atherosclerosis and coronary artery disease. I think we are saturated with that. So let's do something, heart failure, that all of us still have the opportunity to treat. So now, as you know, heart failure, what this talk about is going to be heart failure, not necessarily only advanced heart failure, but heart failure. Most mild heart failures don't come to me. The primary care doctors take care of it themselves. But what is advanced heart failure? Now, easily speaking, advanced heart failure, you all remember your New York Heart Association 1 through 4. If you don't, I will just go over it briefly. Stage 4 is symptoms at rest. All right, that's just easy way of looking at it. Symptoms at rest. They're in heart failure, not doing anything. They're in severe heart failure at rest. Stage 1 is they're able to carry out their regular activities without much limitation. Stage 2, moderate amount of activity gives them limitation. And stage 3, mild activity, like walking down one flight of stairs. They become very symptomatic. Now, most of us walking up one flight of stairs makes us symptomatic, but that's out of just okay. And now what I'd like to do is divide this thing into acute management and long-term management. The goals are different for each one. All right. So let's start with a case. Oh, but before we go to the case, okay. Acute management, what is the goal? Right. Number 1, you want to relieve symptoms as quickly as possible. You want to reverse all the hemodynamic abnormalities, and we'll go through this one by one. You want to prevent end organ dysfunction. Which end organ are we talking about? Mostly the kidneys. All right. You want to initiate patient education and let them know what they have, how to go about prolonging their lives and enhancing their compliance. And then, very important for us doctors, you want to optimize survival enhancing medications. Now, what do I mean by this? In the treatment of heart failure, there have been 1 million studies done. All right. And heart failure, you can now divide the groups of drugs into those that help relieve symptoms and those that actually prolong life. All right. Now, it is very important that after a patient comes encounters the medical establishment with heart failure, they have to go home on the drugs that are known to save their lives, to prolong survival, to improve mortality. It is very important. It is almost malpractice for them not to be on those drugs. So they should be on those drugs unless there is a contraindication. Not an oversight, a contraindication. All right? And those drugs, that class of drugs, those classes of drugs are the ACE inhibitors, your lisinopril, enalapril, and those type of drugs. Your beta blockers. Now, beta blockers is very important. Those of us, like Prof. Duncan in his time, and those of us who he taught, our time, Lawani's time, Dr. Okpong's time, beta blockers were contraindicated in heart failure. And it took people quite a bit of time to convert into giving beta blockers. All right, now, as far as beta blockers go, remember something. There are only 3 beta blockers approved for the treatment of heart failure. Atenolol is not one. No evidence that atenolol helps anybody with heart failure. So remember that. A lot of us use atenolol. We've been using it for years, but it is one beta blocker I would not use in heart failure. Now, what beta blockers should we use? Number 1, the one that's most widely studied is carvedilol. All right, that's a BD drug, twice a day. You start at a low dose. Now, I'm going out of sequence, but I just want to go over these salient points. You start at a low dose. Start at 3.125 twice a day, always after meals. All right, you don't change the dose for 2 weeks. You see if the patient tolerates that drug, and then you go up to the next dose, 6.25. What you want to do is maximize the dose. The maximum dose the patient would tolerate is what you want. those that derive the most benefit from beta blockers are those on 12.5 and 25. All right, but if they can't tolerate 12.5, you go back down. But it's important to try and maximize the dose you give them. Okay, what's the other drug? Bisoprolol. All right, in the US, carvedilol is used the most. In Europe, it's bisoprolol. Bisoprolol, the same thing. You start low, 2.5. This is very different from high blood pressure. High blood pressure, you can start at 5, you can start at 10. But heart failure starts slow because some of them do not tolerate it. And then you will discourage the patient from using a potentially life-saving drug. So start low, 2.5 daily. Then you go up, 5, 7.5, maximum of 10. And you do this every couple of weeks. Some patients, you have to wait a month. The patients that are easy to put on beta blockers are those with hypertension. In those with hypertension, actually even start at 6.25. All right, but those whose blood pressure is 100, they're the ones with the poorest prognosis, and they're the ones who give you trouble. They can't handle any drug. You can't give them lisinopril, you can't give them beta blockers, you can't give them diuretics, blood pressure drops. So you've got to be very careful how you manage those ones. All right, next drugs are the aldosterone type of drugs. Every patient with heart failure should be on aldosterone or eplerenone, one of those two drugs. Eplerenone is very expensive. Aldosterone is cheap, but about 20-25% of them have side effects. The most common one I've seen that they don't like is breast enlargement. At least the men don't like it. And also pain. Okay. And of course, patient education. And number one thing with patients in our environment, number one thing is compliance with drugs, low salt diet, or according to our colleagues, no salt, so they will go to low. And then water. I've noticed many of my patients, you put them on diuretics, they now believe and they're told by their friends and family that you have to drink a lot of water. So they now start drinking a gallon of water a day, and can't understand why they keep coming back with heart failure. So remember, they should drink water when they feel thirsty. I don't think it is important. It's necessary to put everybody on a strict water restriction, but drink water when you feel thirsty. They don't have to drink to try and counteract the diuretics. All right, first case, 69-year-old man. These are real cases, so let's see how we treat them. 69-year-old man, history of hypertension, dilated cardiomyopathy, presents to the hospital in acute pulmonary edema. Okay, patient is in respiratory distress. Blood pressure is 220/120. Heart rate is 130. Respiratory rate is 40. Oxygen saturation on 6 liters of oxygen is 50. ECG is sinus tachycardia, no ischemic changes. So, now this one, where's the microphone? Everybody has to participate. How do we start managing this patient? This is a common scenario. All right, the O2 saturation might not be that common, but it is easily available. But most of us come across this kind of patient, and they die. If this man is not treated well, he's going to die. He's already got some signs that he's doing his best to move over to the other side. But, so, and I can tell you now that this is much easier to treat than a patient who comes with a blood pressure of 70 and all these other symptoms. This one is much easier to treat. You have a lot of room to do what you need to do. So, what do we do? Any suggestions? Any comments? He always has something to say. Dr. Shalaki at the back won't say a word. She just keep quiet. If those of you whose names I know, I'm going to call on you. So where's Dr. Shunaya?
I think at 69, 69, the man is old enough. If he dies, there's nothing wrong. But I said to keep this man alive.
Prof has a comment too.
To keep this man alive, first of all, one has to rest. using drugs that reduce the heart rate, and that is where the beta blockers will come in. So I will probably put this patient on a beta blocker.
On a beta blocker.
Yes.
All right. Any other comments?
Then I will also, because of the acute pulmonary edema, I will have to use a diuretic to pull out
Okay.
some fluid from the system. Because of the poor oxygenation, I may support the patient with oxygen.
He's already on 6 liters.
6 liters, okay, fine. So I will maintain that. I want to know the state of the vitals and particularly the kidney. So I would rather do other investigations, including ECG, chest X-ray, electrolyte and urea plus the creatinine, to know the state of the kidney, because we need the kidney in this particular situation. That is the main thing. With antibiotic, then I will need a blood thinner, maybe aspirin for this patient, because they are prone to embolic phenomena because of the acute pulmonary edema. So I will pump her. And I will take, they will need generous analgesia, because sometimes some of them could be very, very uncomfortable. And empirical use of antibiotic in these patients could also prevent infection in view of the pulmonary edema. I will avoid IV fluid for this patient.
Okay.
I'm seriously bothered about the BP of 220 over 120. If there is no end organ damage already, why should try as much as possible to salvage the end organ damage? So one should slowly bring out the BP to an acceptable level that cannot cause any end damage of the organs.
Okay.
Yes.
Any comments from the back? Anybody else? Yes, sir.
This patient is in acute distress. I would like to use morphine in the first place, then bringing down the high blood pressure, probably something that can bring that one down fast, the labetalol and diuretic.
Okay. All right. Okay, let's start with one. Beta blockers. Not in the setting of acute pulmonary edema. Beta blockers are good long term, but not in this setting. So wouldn't use a beta blocker now. Diuretics. Now, this is where you use intravenous diuretics and you use high dose. Not 20, not 40. You will start with at least 80. I'd probably give this man 100 milligrams of intravenous Lasix stat. All right? I'll give morphine. I agree. But remember, he's breathing at 40. Saturation is 50. He's already in respiratory distress. If you depress his respiration, he might die. So 6 liters is not working. You should change him to a non-rebreathing mask. See if that ups his saturation. Okay? Now the Lasix will help you bring down the blood pressure. Now the textbook treatment for bringing down this blood pressure in acute pulmonary edema is IV nitroglycerin. All right? And contrary to what people believe, it is very easily available in Nigeria. It's just we don't use it. People are actually scared of using it because they worry that the blood pressure will drop. But it's an easy drug to use. It brings down the blood pressure quite nicely. And you monitor the blood pressure. As opposed to intravenous nitroprusside, which brings down the blood pressure very, very fast. And you have to really, really monitor that blood pressure. But good thing about both drugs is when the pressure drops, you stop the drug, within 5-10 minutes pressure starts to come back up. So you don't have to be too scared of the drug. But intravenous nitroglycerin is a very good option for this man. Okay? So I wouldn't give beta blockers. Digoxin has no role here. The role here is IV Lasix, high doses, IV nitroglycerin, or IV labetalol, IV enalapril, anyone you have to bring down the blood pressure. If you don't have those things, give oral and still try and bring it down. You can even give Novask and things like that. But whatever you can do to bring the pressure down, whatever you have available, hydralazine, anything. But the best is intravenous nitroglycerin. Okay. Now, there's still some more that can be done. And let me tell you what, let me try to remember. What did we do on this patient? This is a real patient. Okay. Started went up on his oxygen, no improvement. Of course, you need IV access. Like I said, people as sick as this, you need two IVs because they're moving around. IV will pull out, and when you need to do something fast, they have no IV. Patient was intubated, put on a ventilator. Now, I agree, this is not always available, but if you see somebody this sick, you need to start trying to see how you can get him to where they have this available. Because if you keep this person in your office, he's going to die. He's just going to die. He's too sick. And this guy took about, usually when you intubate them, you bring the blood pressure down. After 24, 48 hours, they improve, and then you can take them off the ventilator and things like that. But this guy without the ventilator had no hope. He had no hope. He was very sick. When you're breathing at 40, you are already at your limit of being able to try and compensate, and you get tired and you just go. Okay, what else do we do? Drugs, intravenous Lasix, intravenous nitroglycerin, and like you said, blood thinners, enoxaparin. This guy is probably unable to take aspirin at this point, but if you can give aspirin, good. All right. Most people, want to put the endotracheal tube down, you put an NG tube down as well, and you give things like Pepsid or any PPI to prevent stress ulcers. But once they're on a vent, pulmonary edema, on anticoagulation, they are at very high risk of bleeding. Okay, so you give high dose of intravenous Lasix, nitroglycerin, subcutaneous enoxaparin, otherwise known as Clexane. Okay, what are the other drug options? There's nitroprusside, which is nipride, a very potent vasodilator. Very, very potent. In fact, usually you should not use it without an arterial line so you can monitor instant blood pressure. Should not be given unless it's in a CCU with experienced people. The drug is not used much anymore because nitroglycerin tends to work. Now, another drug I use a lot is dobutamine. Dobutamine is an inotrope. It's given intravenously. Now, if you remember your basic physiology, dobutamine is a beta stimulant. All right, so it stimulates the beta cells, which improves contractility and also increases heart rate. And it can actually vasodilate and drop your blood pressure. So dobutamine will vasodilate. It will help with the blood pressure. It will improve cardiac function. So it's a drug we use a lot in people in pulmonary edema. Nesitiride is not available here. That is a natriuretic peptide that vasodilates. It improves renal flow, works against aldosterone, and improves contractility. A very nice drug, but it is not available here. Milrinone is similar to dobutamine. Same kind of drug. These drugs are all given intravenously. And dopamine and dobutamine are in the same class. Dopamine has more alpha functions, which means it causes more vasoconstriction. So in a patient with blood pressure of 220, I won't use dopamine. But if his blood pressure was 80, then I'd use dopamine instead of dobutamine because you need the blood pressure to come up as well. So in this case, this patient went on dobutamine and nitroglycerin as well as intravenous Lasix. Okay, this is the endogenous BNP. It's called brain natriuretic peptide. Now you should all know what this is because it's one of the tests we do to see if the person is in heart failure, BNP. Why it is called brain, I'm not really sure, but it's called brain natriuretic peptide. It is found usually in the endothelium of the heart, usually in the atria. Now, anytime the atria are distended, like in heart failure, the BNP goes up. So BNP is a good test when you are not sure what is causing this person's shortness of breath. Is it heart failure? Is it COPD? Is it emphysema? Is it pneumonia? And many of these patients come with all of them. So if the BNP is high, then that tells you it is heart failure. It is not lungs, it is heart failure. So what are the treatment strategies? One, diuretics. Diuretics will reduce your fluid volume. Okay? Vasodilators, they reduce preload and afterload. Now, just to refresh your memories, I know many of us left physiology a long time ago, but preload is your venous return, and afterload is your arterial circulation. So afterload brings down your blood pressure. So when you decrease afterload, you're bringing down blood pressure. Drugs that do that are ACE inhibitors, hydralazine, isosorbide. They all bring down your afterload. Now, preload is the venous return. So that dilates the venous system and reduces the pressure in the lungs. And the drugs that do that are your nitroglycerin, type of drugs. Okay. Now, inotropes are the drugs like dobutamine, dopamine, and digoxin. Digoxin is the one we use most commonly. Now remember, I've saying digoxin 10 times, so you remember digoxin, because there's something coming up, and I want you to remember digoxin, and we'll see if you get it right. Okay, so but digoxin is not useful in acute heart failure. Of all the drugs we use for heart failure, digoxin is probably just slightly better than placebo, even though we use it a lot. Slightly better than placebo. All right, and natriuretic peptide, used a lot in the US. It works just as a diuretic does, without affecting the kidneys, without affecting renal function. So it's a good drug. It's given intravenously. Okay, what are the other options? Intra-aortic balloon pump. I'm sure you've heard of it. You might not have seen it used, but it's used quite a bit in heart surgery. I know they use it in LASUT quite a bit. Anytime they do any heart surgery in LASUT, they use the intra-aortic balloon pump. Ultrafiltration is a special type of dialysis. The nephrologist will know about that more. And then there's a left ventricular assist device, which, if you remember, Dick Cheney, former vice president, that's what he had before he had his heart transplant. Has he had a heart transplant now? Yes. I think so. But he had a left ventricular assist device. I'll go over those ones. So this is what an intra-aortic balloon pump is. It is put in the abdominal and thoracic aorta, just distal to the left subclavian artery. Now, the balloon extends from there all the way down to below the renal arteries, just above the bifurcation of the iliac. All right, it's a long balloon. You put it in through the femoral artery, and what it does is, during diastole, the balloon inflates. It's connected to a console that inflates and deflates. It's inflated with helium. But if the balloon ruptures, you don't want air going in and causing problems. But helium will dissolve in the blood and not cause any trouble. So you inflate it during, it's timed with the ECG. So during diastole, it goes up. During systole, it goes down. And what that does is, remember, coronary blood flow happens during diastole. So during diastole, it goes up, it pushes blood back into the coronary arteries and improves coronary perfusion. Alright, it enhances pulsatile coronary flow, which improves the oxygenation of the ventricle. Then, during systole, it goes down, which actually reduces your blood pressure as it's going down. So it reduces afterload and reduces myocardial consumption of oxygen and increases your cardiac output. Now, this is a life-saving tool that is used when the patient is in extremis, but it does save lives. And we have used it here several times. So just know that these things are no longer just textbook. We are doing these things in Nigeria, and we need to keep up with what is going on. So you know that these things are available. Proven outcomes for heart failure therapy. Like I said, ACE inhibitors improving long-term, improving survival. ACE inhibitors, ARBs, beta blockers. And don't forget, the beta blockers are carvedilol, bisoprolol, and metoprolol. I forgot to go over the dose of metoprolol. Metoprolol that works is long-acting metoprolol, metoprolol XL, at least 150 milligrams daily. So giving 25 BD of metoprolol is not going to work. And of all the three drugs, metoprolol has the weakest evidence. So in those days, a few years ago, we didn't have bisoprolol and carvedilol because they were expensive. Now they've gone generic, and they're actually cheaper than the metoprolol. So there's no reason not to use metoprolol. And atenolol has no room here. Your spironolactone, and in black people, which most of our patients are, hydralazine and long-acting nitrates. And I remember when this study came out, when they showed hydralazine and combination of hydralazine and nitrates worked in black people, didn't work in white people. I was presenting the case, and one of my partners asked me, "What about me?" I said, "Well, I don't know. Maybe I take half the dose, and so it will be half-half, since I'm half." So I don't know what the dose is in half caste, but in black people, it's regular dose. Okay. Now, what are the drugs that keep the patients out of hospital? All right. The same class of drugs: ACE inhibitor, ARB beta blockers, this drug, but also nitrates and digoxin. And it's not on this list, but diuretics. Very important, diuretics. But also note something. The higher the dose of diuretic your patient needs to be stable, the worse the prognosis. Those that require high doses of diuretics don't do as well as those who don't require diuretics. It does not mean don't give them diuretics, because they need the diuretics. But just remember that if having to put somebody on 80 TDS of Lasix, he's not going to do as well as somebody who needs only 40. So just remember, those ones need to be followed more closely. Second case, 55-year-old man, dilated cardiomyopathy, underwent extensive evaluation in India. He went for surgery, but they sent him back. Said surgery was not an option. His echo showed a dilated cardiomyopathy, ejection fraction of 15%. When this patient came about 3 years ago, his angiogram was normal, ECG, normal QRS, everything done in India. So they told him that nothing they could do, pretty much sent him back home to come and die. But you see, these are his drugs. He was on digoxin, Lasix, lisinopril, aldactone, and atenolol. And look at the doses. Lisinopril 5 milligrams daily, atenolol 50 daily, digoxin 0.125, and Lasix 40. Okay, symptoms: dyspnea at rest, 4-pillar orthopnea, raised JVD, bilateral rouse 2/3 of the way up, summation gallop, BP 130/90, heart rate 95, 3+ pedal edema. So, what next? Well, I won't ask too many questions this time, but what did we do? Very simple. Stopped his atenolol. Started him on carvedilol and did this. He was admitted for about 3 days, but stopped his atenolol, switched him to carvedilol. Started on low dose because he was in active heart failure. You don't maximize the dose of carvedilol while they're still in decompensated heart failure. You've got to wait till they're moving around. Increased his Lasix, gave him IV Lasix, got rid of the fluid, got rid of the acute failure, increased the lisinopril to 20, brought down his blood pressure. And anyway, he hasn't died yet. This is about 3 years ago. So he's now on carvedilol 25 BD, lisinopril 20, aldactone 25 BD, digoxin 0.125, and he's doing a lot better. So remember, these patients, if you treat them carefully, these beta blockers are almost like a miraculous drug. If you're able to get them to 12.5 and 25, you'll be surprised after 6-8 weeks. You'll be surprised how much improvement in their functional classification they get. So do not be afraid of these beta blockers. They are life-saving. Very, very life-saving. When I was in the US, I had several patients who were scheduled for transplant, waiting for their transplant. Then carvedilol came out. We started using it, and many of them went back to normal ejection fractions and things. So this drug is really a big, big breakthrough in cardiology. So please, don't forget, use these drugs. Okay, so what are the advanced therapies? Now, I mentioned ICD yesterday, intracardiac defibrillator. Remember, it does not improve the patient's lifestyle, does not improve his symptoms, but it does prevent sudden death. All right, so anybody with an ejection fraction under 30% should have an ICD. Only trouble is it's expensive. So we have to find a way of paying for these people, but like I said, it costs 1-point-something million. All right, 1.7 actually, yes. Next thing is cardiac resynchronization therapy. That's a big word or a big phrase. Now I'll show you what that is. But that's also something that looks like an ICD. It's like a pacemaker. You put it in the heart and it resynchronizes the heart, and patients do improve. About 50% of them go from stage 4 to stage 3 and stage 2. And it actually improves survival as well. And the synchronization is also coupled with an ICD. Intra-aortic balloon pump, we went that, and a left ventricular assist device, I'll show you what they look like. And then a heart transplant, which is not yet available in Nigeria. I don't know when it's going to be, but I think it's going to be a long time. Okay, so this is what heart failure looks like. This is where the CRT comes in, cardiac resynchronization. Now in heart failure, you see the septum here. Instead of going this way, it's going towards the right ventricle with contraction. Can you see that? Are you seeing it or it's not clear? So it's supposed to go inwards. You remember the echo from yesterday, the walls constricting. This is ballooning outwards. This is not moving at all, but this is moving inwards, all right? So this is an almost normal heart. This is heart failure. Now, I'm going to show you the difference between systolic dysfunction and diastolic dysfunction. Okay. Now, what does resynchronization mean? This is an animation of a left bundle branch block that you see on ECG. So what is it? This is the sinus node here. Impulses come down to the AV node. Then they're delivered down the AV node, go down to the right bundle and left bundle. But you can see here, the conduction goes to the left bundle late. You see that coming after the right bundle. That's what a left bundle branch looks like in the heart. So when you see it on ECG, this is what it looks like. It's going down, electricity is going down the left side slightly later than the right side. And this is where cardiac resynchronization works. It tries to resynchronize this and get electricity going down at the same time so the heart contracts more efficiently. Okay, this is after resynchronization. You can see the bundle is now, they're all lighting up at the same time. Is that easy to understand? Okay, so that's what cardiac resynchronization is. Okay, and this is how it's put in. One lead into the right ventricle. This is done percutaneously, no cutting of the patient. Another lead into the coronary sinus. Put that there. And then another lead into the right atrium. This one doesn't have that. Oh yeah, it does. Okay. So you have 3 leads. So the one in coronary sinus goes to the left ventricle. That's why it's called biventricular pacing. So you have a lead in the left ventricle, a lead in the right ventricle, electricity going down both ventricles at the same time. So that's what that is. Okay, now you've heard of systolic heart failure and diastolic heart failure. This is what diastolic heart failure looks like. Alright? The ventricle is thick. The cavity is small. And you can see all the blood is squeezing out. All the blood is squeezing out. So it's squeezing quite well. Squeezing very well. But it is thick. It doesn't allow enough blood to stay in. So the volume of blood it pumps out is small. So that's what diastolic dysfunction looks like. Alright, now this is heart failure again. You see the left ventricle ballooning out, blood staying in. You see the right ventricle, everything is squeezing out. Right ventricle is normal, but the left ventricle, this is systolic dysfunction. Okay, this is comparing after CRT. You look at this side here, you see this is ballooning out, but this is staying still. So what's happening is it's resynchronizing the heart and making it work more efficiently. So that's what the CRT does. Unfortunately, it's expensive, about 3 point something. Alright, and this is what an ICD does. ICD is on, person goes into ventricular fibrillation, it detects it, and then it sends the electrical shock down, and person comes back to sinus. So this is what an ICD does. And now, those of you who've heard us about putting in pacemakers, ICDs, defibrillators, this is the incision we make. It's not much more than this. It's done under local anesthesia. It's not open heart surgery. You put a sheath there into the left subclavian or right subclavian, whichever side you choose, and then you make a really small incision here. You put your lead through this sheath, you advance it down through the subclavian into the right ventricle, and you screw it in. And that's the procedure. It is not a difficult procedure. It is done percutaneously under local anesthesia. And this is done many places in Lagos and Ibadan, Ife, Ilorin, Enugu, and Port Harcourt. Those are places that put in pacemakers now. So always remember, your bradycardic patients, they don't have to go to India. This is done quite routinely here. It takes about an hour. Okay, this is what a left ventricular assist device looks like. This is what Dick Cheney had for a while. You can see it's a very bogus big device. The initial ones were big like this, and you have tubes in the right atrium, left ventricle, left atrium, left right ventricle, pretty much doing a bypass. This is what it started out like, but then there's a portable device like this now. This is what Dick Cheney was using around for a while before he had his heart transplant. And this is what it looks like. There's a tube into the aorta and a tube in the left ventricle. So what that does, it bypasses the left ventricle and oxygenates the heart without it having to go through so it rests the heart and makes the body more efficient. Okay, yesterday I tried to show you a stent. This is what a stent looks like. This is the carotid artery. This is the offerta stew here. This is a wire going down. This is a basket to prevent debris from going into the brain and causing a stroke. You put a balloon over the wire. You dilate the balloon. You push the clot back. You see some debris going up there. You hold it out with that net. Then this is what the stent looks like. You put the stent in, and then you redilate the stent, and you open up the vessel. And this is also done without surgery. Percutaneously, under local anesthesia, patient is talking to you. Alright, this is what you try and do when you see a blood clot. This is a blood clot to the heart. And then in this particular one, laser was used to dissolve the blood clot. Laser is not used often because it's very expensive. Very, very, very expensive. So even in the US, they don't use it that often. But you can see all you do with the laser, you just take it across, it obliterates the clot and clears it out completely. It's the nicest thing to do for a heart attack, but it is very, very expensive. It's used in less than 1% of institutions. And, yeah, because of the expense. Because we can do it with just regular balloon. And if you make a mistake, you can make a hole in the vessel. But if they give us money to do things, it won't be laser I will buy. If let's say they gave us $1 million, it won't be laser. It's too expensive for most hospitals. You have to use it for other things to make it worthwhile. I used to use the laser because of it was a research protocol for us. Okay, just to show you some of these rhythms. What they look like animated. This is normal sinus rhythm. Look at the atrium. Look at the atrium contracting one and then ventricle contracts 1 to 1. So atrium P wave before the ventricle in synchrony. Look at AV block. You see the heart is the atrium contracting 3-4 times before the ventricle contracts. So this is what AV block looks like. Alright, sinus rhythm 1 to 1, AV block about 3 to 1. Alright, this is what AFib looks like. You see the ECG that you were shown yesterday. This thing's not playing continuously. Look at the atria. There's no real contraction, they're just fibrillating. But the ventricle is contracting. Albeit at a fast heart rate, but the ventricle is contracting. Atria are just going away at an undetermined rate. And this is what ventricular tachycardia looks like. See the rhythm? Now look at the atria in this ventricular tachycardia. Alright? The sinus beat is still going at about 70 here, while the ventricle is going at about 200. Alright? So there is AV dissociation, which you can see on ECG, which helps you determine. So the fact that there's a sinus rhythm does not mean they're not in VTAC. It just means the VTAC has gone crazy and is going faster than the sinus beat. Okay, this is ECG. Were you able to print it out? Oh, please just give it out. This is ECG of a patient I saw when I left here last night. And if you get the diagnosis, I'll buy you dodo. Fried with palm oil. This will tell us if you were listening to yesterday's talk on atrial arrhythmias. Because I remember he showed one of these ones. I think I've deleted the computer interpretation so you don't get misled. Any offers so far? What is the rhythm? Or does anybody see anything unusual about ECG? There are about 4 abnormalities there. Bring out your glasses. Yes, that's correct. There's no P wave. Excellent. Excellent. That's not the Dodo prize yet. All right. No P wave. Very good. What about the QRS? QRS. Okay. Let me give you a clue. Is it narrow or is it wide? It's narrow. Okay. So that means it is from where? Is it from the ventricle, from the atrium, or AV node? Atrium, well, maybe. But you know it's narrow, so it's above the AV node, or AV node and above. It is not from the ventricle, it's not from below the His bundle. His bundle, it will be wide. Okay, what's the rate? You can check, the computer reading is there for the rate, so you can check that one. Okay, so it's 100 beats per minute. Okay. Alright, so no P waves, narrow QRS tachycardia. What are the potential possibilities? Is it an atrial tachycardia? No. Can't be an atrial tachycardia because you don't see P waves. Alright. There are no P waves there of any sort. It is regular, so it is not likely to be atrial fibrillation. Alright. It's not atrial tachycardia, it's not atrial fibrillation, it's not ventricular tachycardia. Anybody have? He said this yesterday. Huh? Not quite. Not quite, almost. Go a little lower. Junctional tachycardia. Alright? So this is an accelerated junctional rhythm. Junctional rhythm goes at about 60 normally. Alright? So this is accelerated. This is going faster than the inherent junctional rate. Okay? Sometimes you'll be lucky to see retrograde P waves. Sometimes. But I don't see any clearly here. Okay? What else do you see on ECG? If this person was having chest pain, would there be anything that would concern you on that ECG? Elevation? Or depression? Yeah. There's significant ST depressions. Alright? But look at it again. You should remember this from school days. It always came out in exams. What is the shape of this ST depression? Is it upsloping? Downsloping? Is it coving? Downsloping ST depression. Now, if this person is having chest pain, this is a serious ECG. Very serious ECG. But this person was not having chest pain. The family brought her because she just wasn't behaving normally. 70-something-year-old lady. She wasn't behaving normally. She didn't feel herself. And her doctors were in Enugu. And we had to call and find out what was going on. Okay. So what could cause this? I know many of us are told to do exams now, but that man from MDCN said we're going to do recertification. So this might come out. Yeah, so what? This one and all my medical officers got it wrong yesterday. They even didn't understand why I got on the phone and called the doctor in Enugu to find out what drugs was this patient on. This is digoxin toxicity. This is textbook accelerated junctional rhythm, downsloping coving ST depressions. If you see an accelerated junctional rhythm, it is ditch toxicity until proven otherwise. The same way you see a heart rate of 150, it's atrial flutter until proven otherwise. I called the doctor, said yes, she's on digoxin. I said, what dose? He said, oh, he increased it to 2.25 BD because her heart rate hadn't come down yet. And the lady now decided that, well, let me just go on and increase it to 3 times a day herself. So you see, it's not often you get to see this kind of ECG. I just walked into it yesterday and the doctors couldn't understand why I was so excited. They just didn't understand my problem. I said, yeah, well, don't worry. You will understand. So unfortunately now we can't get digoxin levels that easily. It's very difficult and very expensive. We've called Pathcare, Cleaner Lab and Co. They're going to have to send to South Africa like 40-something thousand naira. I don't know how to tell the family that they should pay 40-something thousand naira for a test that I really need just for my own interest. But this is what, this is textbook digoxin toxicity. So I was just excited I saw that yesterday. I thought, well, we'll bring it here and see. So accelerated junctional rhythm, it's ditch toxicity until proven otherwise. All right, thank you. Any questions on anything in cardiology?
Concerning the management of heart failure, some of the patients we see in our hospital, they usually come with a normal BP. 90, 60, normal blood pressure, and the normal blood pressure, 90, 60, 100 over 70, and they'll come in failure. Do we still need to give all these ACE inhibitor, carvedilol?
Yes, those are the patients that are difficult to manage, the ones with low normal blood pressure. Well, what you do is you start these drugs low dose. And you don't start, so you won't start your bisoprolol and your lisinopril and Lasix all at once. All right, if they're in actual failure at the time, first diuresis them with your Lasix, get them stable. Then when they come back, even if the blood pressure is 95, 100, you can start real low dose. Bisoprolol is gentler on blood pressure than carvedilol. So if blood pressure is an issue, I start bisoprolol 2.5. And then watch them. Now you give them the first dose in front of you. Always after, always after food, never on an empty stomach. Give them the first dose, let them wait a couple of hours while you're there and see how they tolerate it. And then you start giving them, you give them for a couple of weeks and see how they do. Now those who with very low blood pressure, what I tend to do is give it to them after supper. So when they're in bed, when the maximum effect of the drug is in play, it doesn't really make them too symptomatic. All right, but when you give them in the morning, they tend to just crash around 10, 11, and they're just not functional. So that's how I would start. Start with one. And now, which one do you start first, the ACE inhibitor or the beta blocker? My partner, Dr. Kofo, starts with ACE. I start with beta blocker. But I don't think there's a right or wrong. It's just a preference. But you start with one, and then you try and see if you can go up a little bit, and then start the other one. Majority of them will tolerate something. Those who don't tolerate something are usually in hospital all the time. They're just sick people. They're very sick, and they don't do well.
Yeah, sir, you mentioned dioxin, dioxin in the case 2, but in the first one you didn't mention dioxin use. And then in this ECG now you mentioned the toxicity of dioxin. When is it safe to give the dioxin, or when is it not safe?
Okay, digoxin is a useful drug. It's not the most important of drugs. It doesn't affect your blood pressure, so you can give it to most people. Now, because we don't have the ability to get a digoxin level here, I tend to do 0.125, so we don't get ditch toxic. All right, but in acute heart failure, if the person is already on digoxin, there's no need to stop it. But if they're not on digoxin, it doesn't make a difference in the treatment of acute heart failure. Once they're stable and going home, you can add digoxin. But immediately there, when they're in pulmonary edema, digoxin won't have any effect. Only time to use digoxin is if you have AFib, rapid response, heart failure, and you don't have any other drugs you can use to slow down the heart rate. Then you can give digoxin to try and slow down the heart rate. But at that time, if they're digoxin virgin, they're not been on digoxin for any period of time, you can give 0.5 start, then wait a couple of hours, give another 0.5. Give 1 milligram loading dose to try and slow down the heart rate. But that's the only time I use it that way. We can give it intravenously, but we don't have intravenous digoxin here. So digoxin has very little role in acute heart failure. But long term, it does help. But not with mortality, it helps with symptoms.
Any other question?
When you were talking about the laser approach, you said there is a complication. As you were about to say, somebody asked the question and you didn't tell us.
Okay, yes. You see, the laser is laser. It burns through anything. So you have to direct the beam directly at the clot. If the beam goes sideways, it will go through the artery and perforate. And it's not a nice thing. It's not a nice thing. I remember the first patient I saw do that. It was hell. And her name was Mrs. Johnson. I remember very clearly. She just crashed immediately. We knew there was trouble. She said, am I going to die? Am I going to die? She almost died. But luckily, we got her to the operating room and salvage everything. But there are devices you can use to even deal with that. Even in angioplasty, patients perforate. I've done angioplasties here where they perforate. You just go there and tamponade it. You put a balloon inside and wait for it to heal and blood clots form over the hole and seal it. So, yes, every procedure has a complication. Once you decide to go into somebody, one of them will give you a problem that you don't expect. But the best thing is to always be cognizant of these complications when you're doing the procedure.
The blood thinners like aspirin. Many people use Visoprene, but we were told that Visoprene in that low dose of 75 and 81 milligrams is obsolete. That now we should go for 325 milligrams. At the lecture we attended with Professor Dynasty, he was actually, but he was really, really terrible against the use of 81 and 75 milligrams of Visoprene. And he is in favor of 325 milligrams. Now that is the current trend now. I didn't even hear you mention anything like all these blood thinners in the course of your management. Since this patient is most of the time static and they are prone to other blood dyscrasias. Please, what is your comment?
Okay. Oh no, I talked about aspirin ad nauseum yesterday. I'll just talk about the acute setting of this one now. Acute setting for heart failure, aspirin is not a big deal. It's enoxaparin or heparin. All right, but the dose of aspirin in the U.S. the dose is 325. In Europe, it's 75. In Canada, it's 75. Some places use 150. The reason there's such a variation is nobody knows the right dose. Studies have shown 75 works. Studies have shown 300 works. No study has shown one is better than the other. So that is why there's such a variation. But one thing is clear. The enteric-coated aspirin is not as effective. And Visoprene is enteric-coated. So if you're going to use enteric-coated and use 75, you're probably getting maybe 30. As opposed to using 300. So I'm sure where Prof was coming from on that one. The enteric-coated ones, the absorption is not good. So when we put in stents it is critical that you're on aspirin. I make sure it is not Visoprene. I make sure it is regular aspirin, 300 milligrams or 325 for a stent, a heart attack. I don't use 75. But the truth is, nobody knows the right dose. We just know aspirin works. And nobody has the courage to stop aspirin and then compare it with... can't. The other question is, who should be on aspirin? The truth is, nobody knows anymore. All the studies keep coming out with conflicting data. So, bottom line with aspirin is this. For preventive maintenance, for primary prevention, aspirin should be for people with more than 2 risk factors for coronary artery disease. Other than that, the risk of bleeding outweighs the benefits. So, just a regular diabetic, no other risk factors, I won't put him on aspirin. But if you've got diabetes and high cholesterol and is above 50, I'll put him on aspirin.
Please, I want to know how long we can place the patient on Lexis. Is it a lifetime drug or it has a limited duration of use?
That's a very nice question. Lasix does not have to be lifetime. Lasix is purely to treat symptoms. So if a patient comes in with heart failure, you put him on Lasix. Let's say 80 BD for 2 weeks. Heart failure resolves. You cut Lasix down to 40. They're still fine. You can stop the Lasix and see how they do. If they don't go back into heart failure, they don't need the Lasix. Lasix has no effect on survival. So Lasix is not a lifetime drug, but the beta blockers, ACE inhibitors are. And remember, the person should also be on aldactone, so they already have a diuretic as well. So Lasix is not a must at all. In fact, I'm always happy when I can take my patients off Lasix because that shows they've moved into the good prognosis category.
I also want to ask, how long can a patient be on Clexane? When, yes, most times they say a long-staying patient who does not move about, you place the person on Clexane. So, I don't, and you didn't mention it much when you were.
Okay, that's a question we deal with every day. Well, truth is this: you can be on Clexane for a long, long time, but it is not the ideal drug for long term. All right. I have a patient now that I'm not sure what to do. He's on Clexane because he has a clot in his left ventricle. We've put him on warfarin. He's now on 20 milligrams of warfarin. His INR is still 1.1. Hasn't moved. So, but luckily he's diabetic, so he can give himself the Clexane at home. All right. Otherwise, it is difficult to be giving somebody Clexane at home on a daily basis. Clexane is not the drug of choice for that kind of person. All right. That kind of person, if you're worried about risk of venous thrombosis and they're really bedbound, they're not in hospital, you're probably better off giving warfarin. All right. At a low dose to keep the INR about 1.5. All right. But Clexane is just not a long-term drug. Now, the ideal drug for that is dabigatran, Pradaxa. It is available in Nigeria at 60K a month, the dose. I mean, for 150 BD. For prevention of DVT, the dose is less, is 75 BD. But the good news is they say they're launching it next week or 2 weeks' time. It's still not going to be cheap. It's going to be about 15,000 naira. All right, but when you compare that to daily Clexane, it kind of balances out. Compare that to warfarin and checking your INR, it kind of balances out. But 60K, it's only for the big boys. By the time you add 60K, then you add all the other drugs. Your drug bill is about 120, and your salary is 45. It doesn't add up. Also, Clexane is not good for long term.
Thank you, sir. Some people believe that diabetic patients should not be given diuretics. So I want to know your view about this.
Not just diuretic. It's when you're talking about is thiazide diuretics, hydrochlorothiazide. Yes and no, maybe. It depends. This is one of the reasons why the recommended dose of hydrochlorothiazide is 12.5, not 25. There is a small risk of raising the sugar, all right, but it really doesn't raise it that significantly at 12.5. But what you can do is try 12.5. If they need a higher dose, you go to 25. If you see the sugar is going out of control, you stop it and then give a different kind of diuretic like indapamide. All right, but so you don't have to use the thiazide. You can also give Lasix. But yes, thiazide diuretics actually raise your sugar a little, but not that much. But they can make someone like me who's borderline go into real diabetes. But so you would use it. I don't use it at all in borderline people. So they don't, because the label of being called diabetes is devastating to them. So they'd rather just be on their borderline and be going.
But excuse me, sir. They believe that since frequent mituration, polyuria, is one of the symptoms of diabetes, that by giving them diuretic, it will further compound the problem.
Well, hopefully, while you're going through all of this with your patients, then they shouldn't be having polyuria because the diabetes should be well controlled. So it's not usually a problem. And the thiazide diuretics, after about a month, the people don't actually notice that they're going to the bathroom more. But Lasix, they will notice. But Lasix is not what you would use for hypertension. Use it more for heart failure. Hypertension, you use the thiazides or drugs like indapamide, aldactone.
Excuse me. Thank you, sir. Please, what's the role of statins in the management of heart failure? The role of statins.
Statins. Heart failure.
I thought you said Lagactil. I said I don't know. Okay. Statin drugs in heart failure. Okay. Now there's no generalization for statin drugs in heart failure. Depends on the etiology of the heart failure and the person's risk category. All right. If you're just hypertensive, your cholesterol is normal, you have a dilated cardiomyopathy, there's no role for a statin drug. Now, if on the other hand you're diabetic, then there's a role. If you have high cholesterol, there's a role. But if your cholesterol is otherwise normal, statin drugs have no other known benefits.
So just a quick point about the use of thiazides and in hypertensive patients. I think there may be an enhanced diabetogenic potential if you use it in combination with beta blockers. Is that correct? Thiazides and beta blockers predispose more towards diabetes than if you use thiazides on their own.
I've noticed Dr. Shunaya's questions are all on psych. Just an observation.
I just want to know the importance of angiography in cardiovascular disease. Angiography.
Importance of
Oh, I heard that. What's the importance of angiography in cardiovascular disease?
in cardiovascular disease.
In relation to where we are in Nigeria? That's a very tough question. Okay. Angiography is important. Now, what is angiography used for? There's several aspects to angiography. There's diagnostics, there's intervention. All right. Now, in diagnostics, it's useful in coronary artery disease, in patients who you suspect have ischemic heart disease, angina, things like that. Angiography is very useful to diagnose and help you determine what the coronary anatomy is. It is also useful in valvular heart disease. All these are patients with mitral valve stenosis, aortic stenosis. They have to have an angiogram where you look at their pressures in the hearts. You can tell the surgeon what the pressures are because there's some pressures that are prohibitive for surgery. You can look at the valve function. You can look at the LV function. So the angiography also helps you prepare the patient for surgery in valvular heart disease, not just coronary angiography. Angiography is also used to diagnose pulmonary embolism and sometimes treat pulmonary embolism. All right. But CT scan is non-invasive. You can get the same information with the CT scan as far as pulmonary embolism is concerned. Another very important use of angiography is peripheral vascular disease. Peripheral vascular disease, poor circulation in the lower extremities. Vascular disease is common in our people. We are just not picking it up yet. All these diabetics that lose their feet or lose their legs. My dad lost his leg. He had vascular disease. So I'm quite in tune with this vascular problem. It is quite common here. And angiography, after the ultrasound, you do the angiogram, and then you can actually treat the disease before they become gangrenous. By the time the gangrene develops, it's too late. Key is to treat it before the gangrene develops. And then, of course, angioplasty, stenting, closing of ASDs, PDAs are all done angiographically. So all the PDAs that were done in Reddington, they were done in the cath lab angiography.
On the basis of my background, when you mentioned the use of angiograms in the management of vascular disease, particularly in diabetics, is there a place for a preventive angiogram or sort of screening angiogram? Because we have a lot of diabetics.
That's a very good question. Well, the truth is this. Vascular medicine is a relatively new specialty, even in the US. I remember when I started about 10 years ago, I was interested in vascular because my dad had vascular problems. And where I trained to do my angioplasty, the guy was one of the top guys in the US for vascular. So I just had to learn it by force. I didn't understand it at the time. But no, angiography is not the screening for that. The screening is something which is a talk I give frequently. It's something that everybody should be able to do. Number one screening test, which is cheap, it's easy to do, is ankle brachial index. Yes, ankle brachial index, ABI. Ankle brachial index. Everybody should be able to do the ankle brachial index. And all it is blood pressure in the ankles divided by the blood pressure in the arms. So ABI, ankle brachial index. It should be 1 or close to 1. The blood pressure in the legs should be the same as blood pressure in the arms. Now, all you need is a Doppler, regular Doppler that we use. You need a Doppler. You need a blood pressure cuff. You put the blood, and you just need the systolic blood pressure. Now, it's not Doppler ultrasound, just the Doppler that you use to listen to baby's heart and all those things. You just need a Doppler that you use. You put the blood pressure cuff on the legs. You inflate it. You put the Doppler. Once you hear the systolic blood pressure, that's all you need. Where you hear the systolic blood pressure. Then you put it in the arms. You hear the systolic blood pressure. That ratio should be close to 1. Vascular disease is less than 0.8. So that means the pressure in the legs is lower than the pressure in the arms. That means there's a problem with circulation to the legs. Once you get that, less than 0.8, then you should now take all the measures you need to do to prevent that guy from getting worse. and then you send them for ultrasounds, send them to somebody who does vascular so they can prevent problems. But once you get an ABI that is abnormal, number one thing you do is start aspirin. Number two, you start a statin drug while you now work up the patient and see what else they need. But every diabetic should really have an ABI. That battle's been going on in the US. It's now part of family practice and everybody's practice to send everybody for ABI, all diabetics. Well, some people just don't feel comfortable doing it.
It's something you can do in general practice, and we should all be doing. It's as simple as Dr. Johnson has just described it. Yes, ankle brachial pressure index. Okay. About screening tests, as Dr. Johnson has said, they need to be cheap, readily available, and sufficiently sensitive. But it brings me on to my own question. What's one more risk factor we haven't really talked about here, and that's microalbuminuria screening. Is there a place for that, and is that something we should be doing here as a screening test for cardiovascular disease in general?
See, this boy is very, very naughty. He saw me reading up on this thing, so he knew I'm not too hot on this. So what I would say is this: microalbuminuria is important, not just in diabetics, hypertensives as well. So it's a test we do in our office on all our hypertensive and diabetic patients.
Sorry, we can't hear. Sorry, excuse me.
Sorry. Microalbuminuria is an important screening test. And it's a test you should do in your office on all your hypertensive and diabetic patients. And once you see positive microalbuminuria, it puts them at a higher risk. And you take the necessary measures to try and prevent progression of disease. But yes, it is important. And you can't get it from dipstick. No. And it's our own. We send ours to PathCare.
You should talk to me. There might be a business line here for me.
Didn't know that. We send all ours to PathCare.
No. You can do a microalbuminuria dipstick test. It's not a regular dipstick. It's something called the micro test dipstick, and you can actually use it to stratify your cardiovascular disease patients into higher risk and lower risk. Thank you very much. In the absence of any further questions, we will go to lunch.